because I know none of you were a wild child. You're wild child. Maybe you were. Yeah. Oh, come on. You see you're sort of ignoring me. It's okay. This is where I start to take issue with joints, with whoever authored this, the gentleman or the lady who authored this. I don't know. They have it almost completely reversed. The single most important factor when you're talking about joints is this: the shape of the articular surface. Look at the hip. Look at the shoulder. The inherent stability. So I mean, it's all about the architecture. When you see the stability, the remarkable stability of the elbow, how difficult it is to dislocate a hip or an elbow. Inherently, it starts with the shape of the bones as they come together. So I don't know where they got this bit of nonsense. The ligaments are not limited. Effectively, ligaments here secure bone to bone. We use the term ligament a lot. Okay, but ligaments, and when you're studying bones and joints, are the dense, regular connective tissue structures that have collagen and elastin that secure the bone to bone. That's what I drew over here in that sort of bluish color. They hold the bones together. We dissected off all the muscles, all the soft tissue, off of the lower extremity from hip all the way down to the foot and stood it up. It stood up by itself. It didn't collapse when all it had were bones and ligaments. The arch didn't match. It was like they would say, oh, extremely important in reinforcing the shoulder. I'll buy that. Knee joint, not so much. Arches of the foot, not so much. So again, the point I'm trying to make is that clinicians, people who see these things on patients with injuries in sport, know a lot better. Again, this is more of the anatomical view, which is not necessarily the clinical view. And in my mind, not the correct view. So I don't want you to be distracted. So I'm not going to ask you about stuff like that because it'd be confusing. Whereas here, when we look at this, okay, if you're going to be in a field where you have to look at these, or and if I was in lab, I might ask you more specifics about it, but this is contextual. I'm not going to go in and teach every single joint and what it is and what kind it is, et cetera, et cetera. By the same token, in muscles, from what I understand, they talked about origin and insertion. Origin and insertion are traditional anatomy terms. When you studied muscles, you learned an origin and insertion, the name of the muscle, obviously, its action, and then on top of that, nerve supply and blood supply. That's what we learned in med school. It's very different today. We talk about attachments. So even though it says attachment, this idea of immovable or movable bone, there aren't a whole lot of non-movable bones. If you're in the gym and you're doing curls, okay, they're both moving. You can move them both. It just so happens that the one is relatively fixed as your arm. You're curling with your forearm. So this would be where the muscle is here would be its origin. And this is insertion, radial tuberosity. Okay, would be the bony landmark where it's, and so we're talking about the biceps brachii and the brachialis. They both curl together and insert into that radial tuberosity on the radius. What are you doing chin-up? Oh, I'm done with curls. I'm going to do some chin-ups and pull-ups. What's happening now? The fixed point forearm. And your elbow now is not only responsible for moving your arm, but your whole torso. You flipped it. Now this becomes the origin, and that becomes the insertion. So that's why we look at attachments, whether they're medial or lateral, proximal and distal, superior and inferior. Let's look at this. That's a modern approach to it. Now what I would teach, and I'd say, I don't even care about origin insertions. If you know what bones it attaches to and where it attaches, you get an idea. The deltoid spine and the scapula to the deltoid tuberosity. You just figure, just roll your hand over it. Well, if that muscle contracts, I'm going to do this. Okay. I'll buy that. So, and again, if I was in the lab, even in entry-level first-year students, entry-level course, 1,000 or 100 level course, you're not going to ask blood supply, nerve supply, da-da. And so, but they do move along planes, and this is the idea. So you go back to the good old anatomical position. So we'll deal with the non-axial in a bit. So effectively, if it's in one direction, so let's say you're looking at your elbow, flexion and extension, that is a one axis, so the axis of motion, you're in the sagittal plane, actually, the axis, but you're just moving it in one plane. If you're talking about your index finger, you're flexing and extending that, but you're also able to, see the way I do the term, because it's moving in the frontal plane, you're able to adduct and abduct, adduction and abduction. That's why we emphasize the letter, because it's less confusing. Because the add and abduction sound a whole lot alike, but an adduction and abduction, the way you distinguish it, that becomes biaxial. And multi-axial, the only joints that do that are the shoulder and the hip. By definition, your ball socket joints. They have movement in all around all three planes. So when you're in the sagittal plane, it's typically flexion and extension. When you're in the horizontal plane, frontal or coronal plane, you have abduction moving away from the midline or adduction toward the midline. And then if you're talking about some extremities, you can, they call that, it's mistakenly say medial and lateral rotation. In a hospital, every orthopedic surgeon I have ever worked with, internal rotation actually. Classic anatomy, we go medial and lateral. Functional anatomy, we say internal and external. I'm trying to give you both because if you walk into a hospital environment, best to be prepared. I mean, it's almost I look at you, who taught you medial and lateral? We don't use that stuff. So you're a step ahead. And so non-axial are interesting. Those are all those little joints in your wrist. Intercarpal, intertarsal joints. The superior and inferior articular facets between the vertebrae. They do little bits of, they shift here, a little bit here, a little bit there, up, down, side to side. Very little, but again, the accumulation of all of those joints moving produces a fair amount of motion. And particularly in your back, an immense amount, because you have the vertebral discs, they move a little bit. I mean, so you could take a look at Rory McIlroy swing a golf club. You're going to see some pretty good, for a little guy hitting the ball 350 yards all the time. Pretty impressive. That only takes me like 3 shots, maybe 4. Back in the day, I could make 225, 250. Not anymore. My son, my eldest, is like that. We were playing the old course at St. Andrews in Scotland, a one-time deal, and his best friend drove the 320-yard 10th hole. So the different types of motions are these non-axial movements we call gliding or sliding. I just showed you some of the angular movements and the rotation. Here's how you describe them. So this is the flat bone slipping and sliding over one another in similar surfaces. Typically, those short bones have a lot of cartilage. It's real problems if they break because you get blood into the joint and it produces a kind of arthritis that's very significant. We really worry about those. And so this is flat on flat, that kind of thing. So we see, and so sliding, gliding, the accumulation of movement. And so the classic examples of sliding or gliding joints, and I'm coming to where the test question is intercarpal or intertarsal joints, or those processes, not the intervertebral disc, but the superior and inferior articular processes. They're facets forming sliding and gliding joints. They're just showing it to you here. So angular, again, flexion and extension, and some of these are designed like your back. You'll see in the illustration, your back and your neck can hyperextend. It's not that they don't stop when they get to 180 degrees, they can go backward naturally. Other joints, your elbow and your knee can't do that. Typically bone meets bone, and when bone meets bone, something's got to give. Either the soft tissue is going to tear or the bone's going to break. And that's when we see hyperextended elbows and hyperextended knees are big problems. Because they're going to, at the very least, there's going to be a substantial amount of soft tissue injury It has to be treated, if not some kind of. So you begin to see those things that are there. So again, angular movements, flexion, decreasing the angle, extension, increasing it or bringing it back to its original starting point, and hyperextension beyond the original anatomical position. Again, not all of them are by design. So here you can see it at the neck, and they'll show you at the back. Subsequently, with this, the lady they're using as the model, and you can see it here at the knee extension, but you notice they're not going to give you hyperextension. Now, interestingly, the arm, you don't think of it when we're walking like this. You have two muscles that work oppositely. Pectoralis major, latissimus dorsi, they're both technically, even though they support the shoulder, they're both technically arm muscles. And when the pectoralis major flexes the arm on the torso, latissimus dorsi is the opposite. It extends, so you can obviously hyperextend. It's not that unusual. Those are muscles that get a lot of activity in swimming. If you want to see great muscle definition, when you have like national world championship or Olympic year and look at swimmers, when you want to see how muscles work in the lower extremity, same thing, those competitions, look at runners. Oh my goodness. You can really see that. I mean, swimmers have great, they use all their muscles. It's probably one of the sports that use, in the old days, we always thought it was basically swimming and wrestling. To sports that really utilize it. Not so much Greco-Roman, but typical freestyle wrestling. When you see Olympic wrestling. As we continued, if we're in a different plane in the frontal, or some people call it the coronal plane, again, AB and AD. So abduction, moving along, and that's away from the midline. Adduction, back toward the midline. Hyperadduction. You can crisscross. Not that we do it that way. You could. So anyway, your leg's trying to do that. Next thing you know, you're falling down. But you could do that. So that's when we look at those kinds of things. What the unique feature about ball and socket joints is they can do this. So you can isolate the joint, whether it's your big toe or your index finger, and you can trace a circle. It's called circumduction. Basically, they call it, you're tracing a cone in space, but effectively, you're doing that. It's conical. This is the base of the cone, and then this is the tip of the cone, so to speak. And this is what you're tracing that circle. That's called circumduction. And it involves all of these things. So it involves not just flexion, abduction, extension, induction. It also involves a certain amount of rotation as well, which is different, because think of it, when you're doing like your index finger, it's not. You're tracing that circle, but the reality is it's little shifts. As you begin to move it, I can't whirl it all the way around. It doesn't move that freely. Because basically that particular joint is known for flexion, extension, and in this case, a little abduction, a little adduction. You're going to learn that's called a condyloid joint. We're going to get to that when we do the classification. So they're showing you the motions that are there. Medial and lateral are pretty straightforward. So doing this with your head, that's called a pivoting joint. There's only two of those. The other one is radius and ulna, being able to pronate and supinate. Interestingly, there only see those two. C2 and C1, you learned about those in bones, I'm sure. C1 is the atlas, C1 is the axis. The head rotates about its axis. Effectively, the atlas C1 supports the skull, articulates with the occipital bone, the occipital condyles, and then it doesn't have a body, it's just a ring of bone. That dens or odontoid process, that's where it pivots around that. Because if you look at the shape of the condyles, the occipital bone is where you're like nodding, yes, and even tilting it a little bit because of that condylar shape. It does flexion and extension and a little bit of abduction, adduction, if you want to think of it this way. But this just pivots, it goes around, so it's the no movement. You can see this. So there's only two of those joints. I'm going to reinforce that. That's an important point. And so certainly around the humerus, around the femur, you can rotate your shoulder in, hip out, etc. And they're just showing you. And again, we use the term internal and external much more than medial lateral. These are anatomy. The other one is more functional anatomy. from an orthopedic standpoint. The other pivoting joint is the radial head and the radial notch. Period. There's only two. And so if you would lock your elbow at 90, you can still go palm down, that's pronation, palm up, that's supination. If you're lying on the ground, belly down, you're pronated. If you're on your back, you're supinated. Every time we do an operation, we start with the patient. If we're going to use anesthesia, they start on their back. The reason we do that, sometimes they'll just stay on their back. The reason we do that is if we're going to have to move them on their side or on their tummy, what you have to do, it's easier there to intubate. Because if you turn them, if they're anesthetized and you begin to flip them, they could lose their airway. That way it keeps their airway. So I mean, so we operate on hips. Typically, it's on the hip is on the side. When you operate on somebody's back, it's self-explanatory. And if you do a long procedure, let's say a big abdominal surgery, you're going to intubate anyway. Just the length of the procedure makes it inherently important to make sure you have an airway. So there's all these sorts of things. If you go into anesthesia or surgery, you learn about these things. It's really where you begin to find it. And so it's different. In the foot, if you try to flatten your foot out, we call it pronating. You have a flat foot, we call it a pronated foot. You got a high arch foot, it's a supinated foot. If you kind of roll up on your arch, then you're supinating. So we have special movements named for the foot. If you stepped on the gas in the old days, they said you were extending your foot. We now call it plantar flexion. If you bring your toes up towards your nose, okay, now we used to call that flexion, now we call it dorsiflexion. So we're very specific. It was done to eliminate confusion. A lot of these naming conventions that were there, and they're just showing them to you. And again, so I showed you before with an ankle sprain, inversion, sole of your foot, medial, sort of roll over on the outside. When you sprain an eversion sprain, usually in the breaking bones, because bone hits bone. When bone hits bone with enough force, it breaks. That might be a source of one of those high ankle sprains we talked about. And then the jaw is very interesting because you can move it, protracting, where you get to the joint itself, protracting, retracting side to side. That's very different. They just show it to you. And so, and the same thing, we'll talk about the jaw, elevating, depressing. I mean, nobody knows open and close. And I mean, why would you have it identifying? You're shrugging your shoulders. And then famously, opposing the thumb. That is not, again, circumduction. It's a little bit different. It doesn't meet the test when you analyze the motion slowly, step by step. It's like shifting and moving. Shifting and then move, shift and then move. It's not that smooth that you get with the shoulder. That's the reason. It's very similar, but not identical. In anatomy, that's significant. Thankfully, you'll see you only have one of those joints as opposed to you have two, one in each hand, obviously. Summarize. This is the test question. There will be a question. I have it on the I haven't put it there, but I'll be typing it up this weekend. Okay, so it will be A, B, C, D, and E. It'll be 1 in 5 of those 6. Can't tell you which one's not going to be there because I've made up the question. So that's the answer key, because those are the 6 categories of joints. Don't go bananas. There aren't a whole lot. Plain joints, you're going to see intercarpal, intertarsal, vertebrae. Hinge. There's really only one great example of the hinge. More than anything else, that's the elbow. The other ones that are hinges are the interphalangeal joints. So between, we call that the proximal, and we call this the distal. Interphalangeal. Fingers and toes are the same. When you get to the metatarsal phalangeal, the metacarpal phalangeal joints like this, and the ones on your feet, the metatarsal phalangeal joints, they're a little bit different. They have more motion. 2 pivoting joints. The aforementioned C1 and C2, axis and atlas. Head of proximal radial ulnar joint, head of the radius, and the radial notch on the ulnar. Only 2. Condylar, I'll show you there's a lot of. Those are those metatarsal and metacarpal phalangeal joints. The knee is one of those as well. 1 saddle joint, base of your thumb. Very specific. It's the base of the first metacarpal and the distal aspect of the trapezium. So it's in a unique joint. You saw the wrist bones. I don't know how many you had to identify in the practical. The trapezium is really very interesting because if a bone's broken there, it's big trouble. All those little bones in your wrist and your ankle, there's so much cartilage on almost all sides. If they break, inevitably you get arthritis. And if the blood supply is interrupted, some of the bone can die. And then when it heals, it doesn't work like regular bone. It's very. I've seen a lot of those things, and then ball and socket, only two, hip and shoulder. So here they are. So the different types are the plain or flat joints, gliding and sliding only. They're called non-axial because they're not really in one particular axis, depends on their anatomical position. Intercarpal, intertarsal, and between the vertebral articular surfaces, not the discs, not the bodies. Hinge, classic example. That's called the trochlea. You might remember a trochlea here, capitulum. This is the trochlear surface of the humerus. This is the trochlear notch. Trochlea means it's a pulley. So it's like if you're doing pulley experiments, if you did them in high school in physics, and you hooked up pulleys like that. The physics has to do with mechanical advantage. I don't do physics, but effectively, it's wide on the outside, and it comes to that sort of kind of narrows in the center. The exact mate to it in the opposite direction is here. To that ridge on the trochlear notch of the ulna prevents it from wobbling or wiggling. That's why it's almost pure flexion and extension when you look at the ulna. So it's a really good example of it. And the anatomy is not identical, but similar in the fact that the interphalangeal joints, that it restricts that motion. They're really a pretty tight fit. Pretty much, they talk about cylinder and trough, and maybe that's a good way to express it. Pivoting joints. Radial head, radial notch. And the same C1 and C2. The ones we see a lot of and why they're biaxial, as your index finger, any of the metatarsal phalangeal joints, flex and extend, and you can abduct and adduct. The knee is a little different. When you're walking, you step down like this, and you flex the knee just a little bit. It's almost an unlocking motion. If you watch athletes when they're running, you see kneecap will rotate to the inside. A femur internally rotates that way. So this motion is flexion and extension, internal and external rotation. That's because of the menisci, which you're not going to do today. That's knee cartilages. So those are ones I'll be sending you information. We're getting there. And here's that saddle joint. It's like a saddle on a horse. This is on the trapezium aspect of it, and on the metatarsal aspect of it, the first metacarpal base of it is sort of the reverse saddle. And because of that, it's unique nowhere else. Only a right and left first metacarpal trapezium joints. Do you see this? And it allows for, again, adduction and abduction, flexion and extension, but so thoroughly so in the way that they rotate that you can do the opposing of the thumb. And then the ball and socket is ball and socket. Going over a few specific joints, 4 of them, saving the knee, and you're out the door. We're getting here. We can do it. I had to go home sick Monday because not coughing or sneezing or anything like that. It's just like I felt like somebody hit me with a 2x4. My wife didn't do it. There's no bruises. She's always tempted. I shouldn't say that. Lou, you're a pain in the neck. How many football games are you watching, and how many were the Steelers? This is our plight. So these are selected synovial joints. They're important. Start with the jaw. What makes the jaw, it's a hinge. Just like the knee. Just like here. Your attachment here. And what makes so mobile is this is the only place between the sternum and the clavicular, and there's a cartilaginous disc in there that creates even greater motion than what you would expect. This is the only attachment to the upper extremity. The other joints that have that are the knee, we're not even going to look at that today, and the jaw. So the jaw or temporomandibular joint it's a relatively shallow fossa on the temporal bone, and it has one really big ligament. It's only on the outside. So there's no medial collateral ligament. There's just a lateral ligament. So depression and elevation is hinged in that regard, and the side-to-side motion. The most easily dislocated joint in the body because it's a shallow socket, and you really only have support on the one side. And there's a lot of factors. Certainly trauma would be a factor, but bite with regard to teeth, certainly a significant factor. A lot of people have problems with this, and we really didn't start to realize it until a lot of people started to complain about temporomandibular joint dysfunction, how to wear bite plates, how to wear devices to hold their jaw. It really was, nobody knew about this stuff when I was a kid. Why you're having, it was basically just very dismissive. And then I really didn't start hearing about bite to some of the, when I started the dentist, I started to see back in the late 70s and early 80s, start to really get a handle on why this was so much of a problem. So it was something that really didn't make it to the forefront until then. Here's that lateral ligament securing it. That's the good news. The bad news, here's the cartilaginous disc. Whenever you stick something in a joint, not a lot goes wrong. When you have joint fluid, you have surfaces that align nicely with each other. Okay, that's the nature of the joint. So understand it. I should have finished the thought because I went a little too fast. When we go those 6 different types of joints, basically it will be hinge, ball and socket, sliding glide, whatever, and basically that'll be the key, and I'll name a joint. You just have to. There's only limited examples. If it says ball and socket, it's got to be shoulder or hip. Bang, go to the next question. Got it? So whenever you stick something into a joint, it's a problem. Because it's something can go wrong. I mean, it's part of one of the issues with the knee. The knee is the most complicated joint in the body. It's got ligaments somewhere in the joint, somewhere outside of the joint, somewhere part of the joint, and it's got cartilage that's in there, and it's 3 joints rather than 1. Oh, it's a mess. Very useful mess, but it's easy. There's more stuff to go wrong than almost any other joint. That's the degree of complexity. So here's the articular disc. That gets damaged, and when it gets damaged, it allows bad things to happen. So it dislocates easily, mostly because of the socket, and it's not easy to put back in. Never. If you don't know what you're doing, don't try to do it. Most time when we have dislocated shoulders, you have to sedate the patient. Usually we used to inject them with Valium, either intravenously or intramuscularly, kind of gonk, absorb a little bit, and boom. Have somebody who knew what they're doing. Amateurs don't try that stuff. I didn't try that stuff. We had the attendings try it. Senior residents tried that stuff. And I was a senior resident. I still didn't want to try that stuff because you can really do damage if you mess it up. So I always wanted the attending physician to do that, so I knew exactly how to do it. So, and all the pain, tenderness, a lot of things, occlusion of the teeth, people grind their teeth. Bite plates are pretty common. They're useful. I mean, I don't know what the state of the art is today. This is the difference. This is the saga of the shoulder and the hip. The shoulder is all about mobility. The hip is all about stability. Upper extremity is how we interact with the world. We want a lot of mobility to do things, to gesture, to reach, to grab. Our power base and our stable base is lower. And you can't have one without the other. So if I want more stability here, I have to sacrifice mobility. If I want less stability, if I want more mobility here, I have to sacrifice stability. Doesn't matter. You can't have one without having to sacrifice some of the other. That's the nature of it. And the problem here, this is all about the anatomy. This is the worst possible example of a ball and socket joint. You saw the glenoid on the scapula. It's a relatively flat articular surface. We put a labrum or lip around it. That's what labrum means, a fibrocartilage. It deepens it a little bit. This is the analogy. It's like a golf ball on a tee. Even with a lip on it, still about 2/3 of the golf ball is exposed. Without the lip, it's like on a golf tee. And there's not, and believe me, it's how many times you address the ball and you accidentally touch it and the ball falls off all the time. Somebody you're playing with, that's one. Just because they just playing golf for 61 years. I keep trying. Doctors, you have to play golf. It's part of the portfolio. I started when I was like 12 or 13. And what happens, the capsule itself is loose. It's not, these capsules I was talking about are usually well defined and strong. This one is particularly flimsy, so it allows for more mobility. And then on top of it, you have other structures in there, more stuff to go wrong. You have bursal sacs that are in there. This is called the subacromial bursa. This acts, and the way they describe it, this is the long head of the biceps tendon. Biceps has the long head, is like they call it a super stabilizer. It's in a tendon sheath. It goes all the way up and around and inserts into the top of the glenoid. The short head goes over here and inserts what's called the coracoid process of the scapula. So there's there's a certain amount of strength that's there. The problem is it's not enough to prevent relatively frequent dislocations. So we'll show you here. I don't know if there's anything relevant. Not a whole lot there. This is what it looks like. So that glenoid is relatively shallow. There's a lot of head. You can see the cartilage here from the section. The labrum is a rib. And you have it in the acetabulum in the hip. It just makes it a really great socket. Very stable. It adds depth, still only 1/3 of the head. You have ligaments that help to support it. But anteriorly, they're relatively weak. Posteriorly, and I know you learned about it in lab, you have the rotator cuff. So there's 3 muscles on the rotator cuff and their tendons support the joint. There's one anterior, that's the subscapularis. So it's very limited. And if you look at the architecture, go in the lab, the scapula has that bony overhang with the acromion and the coracoid process. In superiorly, posteriorly, it's got the spine of the scapula. There's a fair amount of bone, and so dislocations are predictably anterior. They go forward and down, anterior and inferior. It's the way they always are. And they come from trauma. They come from accidents. They come from sport. We saw a lot of them, not just from those areas. When I was a resident, we had the city prison contract for the city of Philadelphia. And I mean, they would ship them in from a variety of secure institutions. And, if there was a big fight in the yard, they said, oh, the prisoners are having a softball. Absolutely true. Softball game. And we saw some pretty bizarre injuries. No softball game I ever saw like that. But understand, it was like a fight in the yard. And so and they just call us. That was their say, hey, they didn't want any investigation. The prisoners had a softball game. A few people got injured. And we would treat some very unusual. We had inpatient, outpatient facilities for prisoners that were there. So all of this, so you have a variety of ligaments to reinforce it. And this is all the complexity. So on top of all these ligaments, which aren't particularly strong, we have to deal with bursal sacs. And you put bursal sacs anywhere where thick things rub against each other. You either come with the original equipment, like the subscapular or the subacromial bursa, or they form as a result of unusual friction and pressure. And here you can see this tendon sheath is really a modified bursal sac because this thing is constantly moving. So imagine it's constantly moving as we move our shoulder up and down to secure it. And so here you can see that that red, that's the labrum. Here's the glenoid. Here's the capsule. And again, it's more substantial. Posteriorly, bony overhang. Superiorly, that's why it's going to go downward and forward. So you can see that. I'm not going to ask you the names of those. That's lab. rotator cuff. That's beautiful looking, even post-mortem. You can see white and glistening. That's non-arthritic tissue. You see arthritis got little pock marks. It's thick. It's discolored. It's irregular. Sometimes it's just distorted. Sometimes it's very soft. Sometimes very hard. Talk about the arthritis in the one that I send you. And so injuries due to mobility of the shoulder, anteriorly, inferiorly, someone has to know what they're doing to put it back in. This is the part I was talking about with, unfortunately, with the prisoners. We got into some pretty substantial fights. We saw some pretty bizarre things. And just showing you some of the muscular structures that are there as well. Like, for instance, things that help it. This is where the muscles do play a role. Not just the rotator cuff. Pectoralis major technically isn't affecting the shoulder because it inserts on the upper humeral shaft, but it certainly supports it. Deltoid, okay, goes to the deltoid tuberosity from posterior, from the spinous cat. It certainly plays a role. Here's the biceps. Part of it going up here to the coracoid process, the rest going to that super stabilizer, the long head. They're all there, sort of from the side. The big thing about the elbow, hinged, very secure. The radial and ulnar joint is secured by a really important ligament. This is its name, annular ligament. Annular means around or in circles. The collateral ligaments are typically long bones, whether it's a finger, whether it's a toe, whether it's an elbow, whether it's a knee. Collateral ligaments on either side. And it'll either be medial or lateral, or we'll name them for the book. Ulnar is medial, radial is lateral, interchangeable. In the knee, you could say tibial and fibular, or medial and lateral. They're all the same. So they're interchangeable terms. They're really useful side to side. They keep it stable. This is the one that's injured when you hear about something called Tommy John surgery, and we have to replace it. Or nowadays we're using almost like a scientifically designed biocompatible strap, sort of tethering it back into place. So it's strong, but has a little give to it. And you can see it's so well, it's just solidly in there if you can see diagrammatically. Here's that annular ligament. And the collateral ligament isn't just, we don't draw it as one, but a lot of times there's a section going down, a section going across, whether it's here as you're looking at the lateral side, or this is the very famous ulnar collateral ligament, the one I was talking about. They'll drill a hole in the bone, they'll drill another hole here, and they'll create this sort of interesting strap device that's there. And you can look those up if you want to. They're very interesting. That are there it is. And lastly, I know you were happy to hear that term, the hip, ball and socket joint, large spherical head. It's perfect. The acetabulum is so deep. The head is so secure in there that when we would remove the head, when someone broke a hip and we're going to do a hip replacement, when you pulled the head out, and it took some pull, okay, you heard a sound. It was like a champagne cork popping. I'm not making this stuff up. It went like that. And the orthopod I had, the two orthopods I had, the small one weighed about 2 1/4. The big one weighed about 250. He was an ex-football player in college because he had a football scholarship. That, and he pulled that out, and you could hear. I was like astounded. You can't do anything because you're holding retractors. Watching this guy pull it out, I'm like, oh my goodness. And it's made deeper by the labrum. You hear about torn labra all the time in sport. Very common injuries that are there. And so you can see it really, there's a lot of depth to that, about 2/3 of that. And again, it's extraordinarily secure. It's very tough to dislocate a hip. It's very easy to dislocate a shoulder. And you can see this ligament called the ligament teres means round, is vascular. The blood supply to that, and you can see this beautiful white glistening cartilage, even post-mortem, that are there. When that's ruptured or it's pulled out, that dislocates. If that violates that blood supply, that's going to die. That's big. And the ligaments the capsule is strong, the ligaments are strong. Okay. So that ligament and teres are the one going, the head doesn't do anything, it's the artery. Greatest stability, deep ball and socket. You see all those there. And then we're done. We're going to stop at the knee. We're all set. So we got out even a few minutes early. My voice saved you 12 minutes. Thank you very much.